Morning everyone, great to see some familiar faces and a few new ones here at SCAS this year. So I'm going to talk about quite a difficult subject this morning, but not one we should shy away from. What I'm not going to talk about is high performance CPR in kids, because there's much more to this story than that, but I do want to give you the cautionary note. These conversations can trigger stuff for us, so put your head down, think about something else, walk out the room if you get to the point that you need to. Please just look after yourselves during this. So I want to talk about a few things. I want to talk about the context of paediatric cardiac arrest and SUDI and SUDICA in Scotland. I want to talk about some of the myths that come along with the resuscitation of young people and kids. I want to talk about the process, and I want to talk about the review, and all that will make more sense as we're going through it. So, you broke it again, Luke. There we go. So the context. So Scotland's got a bit of an unpleasant secret. We have the worst child death rate in Western Europe in Scotland currently. This is the latest report from the National Hub for Child and Adolescent Death. We have about one SUDI, so sudden and unexpected death in an infant, every 7.5 days in Scotland, which is probably more than people think it is. A lot rings true with the other health inequality stuff. If you live in the most deprived areas of Scotland, so a deprivation score of 1, you're twice as likely to see sudden and unexpected death in children and infants. And it's the stuff you've all heard about previously. There's absolutely still links to rollover and co-sleeping. Smoking, alcohol, drugs, all have a huge impact on this stuff. And because of that, there's work in progress now to try and improve that through this learning, but I'm going to touch on that a little bit later on. I think if you boil that down to what we see as an organisation, as resuscitators, as people who go to these things, this is our latest data. And if you look at right at the top of that, 0 to 9, it feels like first impression, tiny, small numbers, but actually it's not that small, is it? Under 19, there's about 90 cardiac arrests a year. These are worked arrests. These are people who resuscitate. These are not the people that we turn up and don't do resuscitation. That number is even higher. That being said, for most clinicians, it's a once or twice in a career event. So it's impossible to be slick and be on top of your game. And just like Luke's spoken about, it is a heart rate increaser, and it is stressful, and they're not pleasant jobs, and all the other stuff that comes with them. All the other sensitivities on scene and the difficult things we're dealing with are all adding to that burden for us. So there's I think, a few things that we do need to try and think about, and there's some of the myths about it, and I want you just to have a quick read of this nonsense. Who remembers this? GERCALC 2016. Lots of you in the room will be familiar with this. And pie in the sky, like attempting to perform advanced life support procedures in the back of a bumpy, moving ambulance, which you're trying not to fall over in, let alone performing advanced life support procedures, because all you've done on scene is scoop and run, scoop and run. Does that sound familiar? And if you didn't scoop and run, what happened? You would get criticism from your ED colleagues because you should have been here 20 minutes ago. You get back on station and went, you should just have gone, should you not? It's a kid, you need to go. And it's really interesting this, because that's GERCALC's 2016, except before then, there was papers being published in 2015 to say, actually, that's bad. And there's quite a lot of literature about this. So it is a myth that we should still scoop and run, and we still do in about 40% of the cases of paediatric out-of-hospital cardiac arrest we deal with. But actually, if you read some of this literature, if you stay on scene for at least 10 minutes and optimize the resuscitation, we're not asking you to stay there forever, but, secure the airway, get some access, and think about delivering fluids, then actually you double the chance of getting ROSC. So there is some myths out there, that's one of them, and there's one other myth I want to quickly touch on. Kids don't have shockable rhythms. Yeah. And to be fair, overwhelmingly they don't. We all know that it's hypoxia and hypovolemia because of the disease process, and they get sicker and sicker and sicker, and they drop off the edge of the cliff. But tell that to the 3 kids in Scotland this year already who've had VF arrests, all witnessed, all in public places, all with chain of survival that was epic, all shocked by a public access defib, and all alive. So it is rare, but it's a myth that it doesn't happen. Be aware of it. We do see VF in kids, and they do survive it. We see it much more in hospital, but they tend to have existing cardiac disease. But what are our priorities? So we've arrived in the scene. Our heart rate's 640, apparently, at this point, which is fair enough. I'm not very good at driving, it would seem, as well, which is noted. What are our priorities on scene? Well, the first priority, obviously, is to preserve life. And that's regardless of what agency is there, whether it's an ambulance response, a voluntary response, a police response. Often our police colleagues are first on scene at paediatric cardiac arrests. Everyone's priority at this point is to start resuscitation and preserve life where it's appropriate to do so. And like I said, I'm not going to go into this, but that is the first priority. But there are lots of occasions, sadly, where this isn't the priority because either the child is dead and there's nothing we can do, or we've confirmed death on scene. And I think that's where we then start to see this divergence across agencies, where we now have slightly different priorities. So ours would be that confirmation of death, starting that family support, starting that arranging of conveyance still to the emergency department or wherever we're going, which we'll speak about. Our police colleagues now have to start to think about finding a child death senior investigating officer because it's a specific role. They need to help with that support of the families and explain the process in the early periods. And also they need to think about the scene. I think there's an important element to that, which is this. And in fact, I wouldn't say not necessarily a crime scene. Almost always, it's not a crime scene. Now, there's definitely processes that have to be in place that our colleagues in Police Scotland have to follow. So actually, eventually, they do need to lock down the house for a period of time. But before then, you don't have to treat it as a crime scene. So people should be able to move freely around about that house and gather belongings that are needed, for example. The parents should have that freedom to do and go where they need to go within it. And I think this is something that we need to be considerate of, but probably above all else, the thing we need to be considerate of is this. You can't make it better, can you? This is the worst day in history for these people that are all with you just now. It's probably one of the worst days in our careers in a lot of cases. But it can be made worse by actions of the agencies that are involved. And to be honest with you, it used to be. And I kind of want to pause here for a wee second and just give a shout out to a few people. So there has been a lot of work, particularly in the last 5 years, to help us stop making things worse when we're at these scenes. And there's a few people within Police Scotland and the Procurator Fiscal Service who deserve a massive amount of credit, but there's also two others that need a lot of credit. One is Michaela McGlone, who lots of you will know, who's a PEDS consultant in Glasgow. Another one's Dave Bywater, who have worked ridiculously hard over the last 5 years to help us iron out this process so that we don't make this worse and that we make sure all the agencies are working together to ensure that we get all this communication on scene right. And I think that's probably some of the most important bits that we need to talk about today, if I'm honest, not the how we resuscitate someone on scene. So, why do we convey children and young people that are already now dead, sadly? And there's a few reasons for that. And I think probably first and foremost is it affords the family an opportunity to get an extended period of time with their child. And that also then affords that family the opportunity to have extended family, friends, support networks, all get to them and give them that extra support that they're desperately needing right now. And that's probably, from a pastoral care point of view, one of the most important reasons that we do it. So any child, young person, under the age of 18 who's died, almost regardless of the circumstances, although suspicion will be different, should be conveyed to the nearest emergency department or where there's a pathway in place. And I'm going to touch on that again in a bit of a second. It gives people access to religious and other pastoral support and input if that's appropriate, and if that's something they want. We can find this in most of our hospital settings. But actually what it also leads to is referral into bereavement support services. Now, a lot of the time they're not going to be used yet, but that referral is really important, and there's a whole host of support out there, often through charities, and there's lots of charities, things like, Scottish Death Association, Held in Our Hearts, Crews, all this kind of grief and bereavement counselling, all will be helping to support this family through their journey for the future that's going on. And also, it starts a process of just helping them understanding what goes on now. So things like your mementos and brightest star box, that little bit of something for the future that the family can go back to and look at and see and understand. Silly things like a family pack, but they're not silly because actually they've got a letter that explains to the family, because they're not going to remember any of this, what's going to happen in the coming weeks and months. What does this process look like? When will I know what's happened? How can I move on to getting a funeral director? And all these little things that you have to do after death that you think, well, it can't be that difficult. But actually, for these people, it's the most difficult thing in the world right now. And all those next steps are outlined, and it means we can intervene with that help and support early because we've conveyed to the hospital for that ongoing pastoral support. But also, there's a little bit more process that's now required as well, which is tricky. You've conveyed to a healthcare establishment with consultant care. There can be all sorts of reasons that these things have happened, and actually a consultant helping support the family can also be finding out the history of events. There may be siblings, and inadvertently these siblings might be at risk of something happening to them medically as well. And so that history taken can give you links for follow-up care for other family members as part of the process. And also, you're now in that safe hospital environment with a healthcare team looking after them who become, over the next few hours, that safe, friendly face that the family develop a relationship with. And also they now have become a liaison between support and bereavement care and the process that Police Scotland have to follow. So that liaison part is a really important part of this process and another reason for that conveyance. There's a really tricky bit within this, and the consultant who's in charge of the wee one's care now has to do a top-to-toe examination with the senior investigating officer. It's not a forensic examination, it's a look over to say, are there any red flags that we immediately need to know about? And it's a really tricky part of the process. And that's why healthcare is good at this, because they can afford that explanation to the family again by being that friendly face and point of contact. And also they are the people who are going to document all this for future reference. So lots of process involved with this, lots of reasons for doing it, but lots of difficulties that come with it. There's another reason for conveying though, and I think generally for all the ambulance clinicians in the room, it's a bit of a safe space for us as well. It gives us time to get away from the locus. Generally, in most of our emergency departments, particularly the ones that are receiving kids, we know folk that are there and they're good at looking after us, and we can just get a few minutes to clear our own heads and have a cup of tea and decompress a bit. And if you want to do a debrief, I've just put one example up here, there's lots of them out there, but that formal quick chat about what's happened with everyone else that's been involved can be done more easily because we've moved everything away from the scene and we can get the time to ourselves. And I think it's an important message, which is be kind to yourself right now and each other, because they are some of the toughest jobs you'll ever go to. There is still lots of challenges out there with it though. And I want you to keep thinking about that slide. You can't make it better. Don't make it worse. We still have a little bit of a challenge across all organisations and all agencies with a lack of awareness about what this process is, because it's rare, because it's once in a career for most people, and that's across all agencies. Even when the specialist officers come in, they don't deal with it often either. And so knowing that we should convey to the hospital often does become a challenge for us. Sometimes when we speak to the hospitals, they don't realise that the wee ones should be getting conveyed to them. So they may refuse to take them. Or if you're out of area, they say, no, that shouldn't be coming to our health board. And there's one real big challenge out there, which is 16 and 17-year-olds. So in police terms, you're a kid under the age of 18. In healthcare terms, certainly for our dedicated receiving paediatric centres, you're an adult after you're 16, you should be going to adult services. And I think we can pretty much all agree right now, the worst place to get nice pastoral care after you convey them is an adult emergency department in Scotland, and all the chaos that's going on there. So there is now processes in place at Everly Health Board, and we're about to make that available, but they still are a challenge for us on scene, and they can cause us a bit of grief. So that on-scene communication is key, and I think don't be shy about discussing this pretty frankly with our police colleagues and saying, we're trying here, but it's not always that easy. And unfortunately, we have had occasions where it's been a funeral director that's had to intervene so that the young person, 17, 18-year-old, hasn't been on scene for longer. But actually, our biggest challenge, to be honest, all that aside, is the top-to-toe examination. So our amazing colleagues in the emergency departments really, really struggle with this. It's difficult, it's upsetting for them. Often they're doing this some time after the child or the young person has died. They muddle up what's the ask. Am I being asked to do a forensic examination? I'm not a pathologist, I'm nervous about this. And for them, that's probably the biggest challenge that exists. And we're aware of that, but we made it much, much better than it's ever been before. We read at that. It's a pretty powerful statement, isn't it? We're quite behind the curve with a lot of this stuff in Scotland, but we kind of have now got our house in order. Our colleagues in England are very familiar, who've been doing child death reviews, multi-agency child death reviews for well over a decade now, have lots of data and lots of understanding. We're only just catching up since really 2021, but actually mostly since 2022. Any child, so anyone under the age of 18 who has died, gets a multi-agency child death review to look at the circumstances surrounding their death. And actually, if they're a care for child or they have care experience, that goes right up to the age of 26. And it's to look for common themes and to ask questions like, is there anything that we could have changed? Or across an entire data set over a number of years, actually, is there common themes coming out? So the obvious one is rollover during co-sleeping. And we're all familiar with that and the risks that adds to sudden and unexpected death in infants. There was a massive campaign round about that last year, and there's another campaign going to happen in January 2026 about it. And in a meeting with Police Scotland yesterday, they said, actually, this year so far, compared to the 4 previous years, they have seen significantly less sudden and unexpected deaths in infants perceived to have been caused by co-sleeping and rollover. And if you think about those GRCALC guidelines I put up at the start, and think about what it says now, where it says, actually optimise resuscitation on scene before you leave, that came from our data set. We've seen this trend of an increase in ROSC in paediatric cardiac arrest that we hadn't been seeing by the fact that we'd already started pushing optimising resuscitation, and we asked GRCALC to change the guidelines. And actually, we wrote the paragraph for GRCALC. So we have had early learning from this, despite the fact our data set is nowhere near as complete as it used to be. But it's an important part of it. For the ambulance service people in the room, we ask you beforehand, you were at this job, is there anything you'd like to feedback? If you want to come to the child death review, you're welcome to, but most of the time we go to it on your behalf. So the question is always asked out there of you if you want to do it, and if we get any feedback, we'll always endeavour to send it back to you afterwards. But I just want to leave you with one last bit, and this is the 3rd time in SCAS that I've left you with this one last bit, and perhaps on this occasion, it's the most important time I've done it. I'm going to put that slide up that we're all familiar with. I'm going to stop there, and I'm going to thank you for listening to what was a difficult subject. Cheers.